Hi everyone, this is Howard Mann. Welcome to the STR webinar. This week Travis will start first. So he is, I think you might be presenter. Let me just see. Sorry, let me just check. Travis, I think your screen is.
Do you see? Do you see anything?
No, I don't. I'm trying to change
How
present.
about now?
Now I do.
Okay,
Very
I hit
good.
the present
Yeah.
button. Okay,
Okay. Good.
this is a recent case from the VA. 63-year-old man, and came in with this radiograph. He's an alcohol user and drinks a little too much sometimes. I don't know what else his deal is, but you can see here he's got this right hilar mass, and there's volume loss on this side. And there's actually, you see this, his colon, which looks like it's interposed. This turns out to be a small Morgagni hernia that's unrelated to what we actually see that's going on here. But there's volume loss in the lung aside from this Morgagni hernia and this right-sided, right parahilar consolidation. So it certainly looks like there may be some degree of collapse and obstruction. And so he undergoes CT, and you will see that he does have right upper lobe collapse, and it's pancaked pretty medially there, the entire right upper lobe. And then he also has this nodular area of consolidation, more in the superior segment of the right lower lobe. And you can see how it's heterogeneously enhancing a little less than the rest of his right upper lobe. So the question was originally raised on this study, and I didn't get involved until right before the bronch, which we'll see here in a second. But this was called likely an obstructing cancer with right upper lobe collapse. I think the problem is, though, that as you see here, there's not really a mass. There's, it looks like just mucus and stuff in his airway. Now this, on the other hand, this area, not sure, but he did have signs and symptoms of pneumonia and had been recently drinking and found passed out. And so there was a question, does he have a mass here or does he have aspiration? But it's kind of cute that this finding that I'll show you in a second, but this was called a mass. They went to PET, which I guess, in the acute setting is would not always be my first choice. And you can see that there's really nothing in the airway itself. This area is intensely hypermetabolic in his posterior segment of it, or apical, or sorry, superior segment of his right lower lobe. Get it right eventually. But they did bronch him, and you will see what this is right here. This is what they pulled out of that right upper lobe bronchus, and it actually had a little shell to it, and this was an edamame that he had aspirated into that right upper lobe bronchus, and there was no tumor. All the stuff in the superior segment of his right lower lobe just looked like it was adjacent areas of pneumonia and just severely inflamed airways, as you can see here, and thickened. So this adds to our collection. This was the little portion of edamame here. It's a little bit smaller than I would have thought, but that's what they identified it as. So we can add that to our peanuts and our lentils and all the other organic material that we've seen now in airways.
I'm glad he's eating healthy.
Yeah, exactly. Yeah. So
Very nice.
thought that was a cute one. All right. Now this one, let's see. This one now kind of challenges my worldview of cystic lung disease. I'm going to show you. This is one I just came across this morning because this patient's going to be at our interstitial lung disease conference tomorrow. But you look at these cysts that this 32-year-old woman has, and you can see that some of them are triangular or polygonal, and a lot of them are along the fissures in the subpleural lung. So Howard and David, when you see this, what's the first thing you think of with this look of the cysts?
BHD.
Yeah, exactly. Right. And you don't think there's a differential, because that's what I thought that this was too. Now, there are a few more little discrete cysts, but what's interesting about this case is that this is not Birt-Hogg-Dubé, at least not exclusively Birt-Hogg-Dubé. You can see in her upper abdomen that her kidneys are kind of replaced here. I'll show you on the abdomen pelvis CT from a few years ago. Arguably the world's largest AMLs, replacing the entirety of her kidneys. And she has a history of tuberous sclerosis complex. And what's interesting is actually the diagnosis wasn't made until 10 years ago. I'll pull up the brief report. So when she was pregnant, they found that her child had a heart tumor. Subsequently, he underwent genetic analysis. It was a rhabdomyoma. He had tuberous sclerosis. And then the mother was also positive for tuberous sclerosis, and it had seizure disorders too. And the other thing that I think confirms that she has tuberous sclerosis complex too is when you look at her bones on this case, that she has multiple of these blastic bone lesions or sclerotic bone lesions, as is often seen in tuberous sclerosis throughout her spine. And this is actually the second case I've seen like this recently, and the other one was a man that had tuberous sclerosis complex and had what looked like little Birt-Hogg-Dubé triangular cysts. And I found a couple of articles. Number one, this one right here, and because I was trying to figure out if there's some sort of overlap, and I think to make a long story short is yes, there's a little bit of overlap, at least in the genetics of these. The tuberous sclerosis complex and the folliculin genes are both part of this mTOR pathway. And now this case was just one where they described an angiomyolipoma in a patient with Birt-Hogg-Dubé. But I don't know. I've never seen one that, where the cyst looks so much like Birt-Hogg-Dubé, but in a patient who's confirmed to have tuberous sclerosis complex.
That is so interesting.
Yeah, and there are other descriptions like cardiac rhabdomyomas in Birt-Hogg-Dubé, the other clusters of things that angiofibromas in patients with tuberous sclerosis. I wish Seth and Jeff were on here to if they've seen this before. But anyway, this is literally the second case I've seen in a month. I didn't have time to pull up the other one, but it was a man that had the diagnosis of tuberous sclerosis complex, but his lungs looked like this, and I actually sent the clinician a question. I was like, "Are you sure?" And they were sure that he had it based on the genetics. So I guess the take-home point is I thought that you could be 100% confident when you saw these types of cysts with this visceral and more ovoid or triangular shape that it was Birt-Hogg-Dubé, but I guess not.
There's no 100% confidence left, I think.
I know. The other comment I want to make is the sclerotic bone lesions that you often see in tuberous sclerosis complex. I just found this article, and you can see he has these throughout the entire spine, even in the sternum. They look kind of like bone islands, and essentially, I think histologically, that's basically what they are. But this article from Radiology from a few years ago they used the bone island or these bone lesions as a fairly specific way of differentiating spontaneous LAM from tuberous sclerosis complex. And this table right here is, let's see. Yeah, I think this is, or no, it was this table. Distribution number of sclerotic bone lesions in these. In patients with LAM, isolated LAM, only 3% had 4 or more of these sclerotic bone lesions. And of course, this patient has 10 or more. So you're either in the tuberous sclerosis complex with LAM or just tuberous sclerosis complex without in both of those cases. So I thought that was a kind of interesting and helpful finding. So if you ever have, to differentiate between isolated LAM and tuberous sclerosis complex, that this is a helpful finding in some cases.
That's excellent.
I think one finding that goes with LAM in this case, or TS, is the number of cysts.
Yeah. That it's more than what you would just see with Birt-Hogg-Dubé. Yeah.
Mm-hmm.
So, but I thought this was a very interesting and instructive case.
Very. Thank you.
All right, let's see. We'll do a couple more here. This was a cute one. So this is a patient that was transferred in. She had been in a car accident, and you can see it's a nice radiograph. Obviously, there's an abnormal left-sided contour here, and you can see that you see a portion of the descending aortic interface, and we don't really see much of the left paravertebral interface. And when you look on the lateral, it's an awfully subtle lateral. She has a pectus, as you can see here, but there's just subtly increased opacity here. And I guess when she was transferred here, this had been at the outside hospital. They had called this a hematoma in the context of trauma. Of course, it's kind of low attenuation, especially for an acute hematoma, and it's perfect location for a paravertebral or posterior mediastinal mass. And you can also see there's some internal vascularity at least around it, if not frankly right through it. So when the surgeon came to us, I took one look at this, and they did a repeat CT just to follow it up. I'm not sure why, but with this vertical elongation of posterior mediastinum unilateral, that almost certainly this was going to be a nerve sheath tumor of sympathetic origin, like a ganglioneuroma or one of its variants, and they did take this out, and this was a ganglioneuroma. So not a hematoma, of course, and not unlikely to be a schwannoma or neurofibroma, just given the elongated, this vertical orientation of it, suggesting it arises from the sympathetic trunk.
Also, it's got kind of low attenuation of kind of myxoid tissue.
And a lot of and some of this is just the myelin and the nerve elements, right, that are kind of fatty and fluid that you typically see.
So what sort of attenuation do you see there? Can you measure the attenuation?
Sure. My guess is it's going to be teens to 20s. We'll see. 30s. So the mean is in the 30s. So yeah, but still pretty typical look of a sympathetic trunk tumor. All right, I'm going to show one more. This is just a quickie right here. It's along the theme of the aspiration. And you can see, let's see, this is the 2 view. So of course this, on one view, you might think that this is some sort of, on this other one, you might think that this is some sort of nipple decorator of some sort. But of course, on this 2 view, you can see that this is much more inferior than would be expected in a man. And I think you can even see his left nipple shadow right there. And then you see on the lateral view that this is tucked way down in his posterior basal segment of his right lower lobe. And this is just a good illustration of where things tend to aspirate. Unlike the guy, the edamame, who he must have passed out face first when he aspirated it anteriorly. But this was not a diagnostic dilemma. This was a patient that was at the dentist, and the drill bit came loose and ended up right down there. So, and you can kind of see that it looks like one of those little drill bits, and there's the tip on it right there, inferiorly. So normally that's where we would expect aspiration to occur, just since that's kind of a straight shot straight into the posterior basal segment of the right lower lobe. And that made its way out pretty far.
Yeah.
So, nice little cute teaching case. So
What do you think they'll do about that? I mean, it's there.
They took it out. They were able to do a bronch and pull it out.
Oh, they got that far.
So yeah. Yeah, I'll actually, while you're showing, I can pull up the note, because it was like in one of the sub segments of the subsegment of the posterior basal segment or something.
Great.
But I can pull up the report while you're showing a case.
They made a snare out of dental floss, and it was attracted to that.
Huh.
Maybe they had a magnet.
All right.
I don't know.
I'll stop there for now, Howard.
Sure. David, do you have any cases this week you'd like to show?
I could show a couple of cute cases here.
Very good.
So
good. We see yours.
I have a CT scan from pretty early. I think this is 2002. It shows in this young person, I think around this time, he was probably in his late teens, a variety of nodular, solid nodular and cavitary lesions, concentrated somewhat toward the bases, mid lungs and bases, like this, and pretty normal looking airway from what we can see here. So things did not stay the same for this man. Let me bring up the next exam. This is what he looks like now. Currently, this is late 2017. You can see at this point he has left lower lobe collapse, and he has this right upper lobe volume loss and consolidation. In the meantime, he had been treated for squamous cancer in the left lower lobe and was getting treatment for this right upper lung mass, a different squamous cancer. So his lesions, his solid lesions, have given way to these thin-walled cavities, and he's got some abnormal mediastinal tissue. He'd been treated for a variety of laryngeal lesions, and at this point he has a tracheostomy tube in place. So this is respiratory papillomatosis, as you probably tumble to, with squamous cancers derived from this wart disease, first in the left lower lobe, left with collapse, and now in right upper lobe. So respiratory papillomatosis progressing in this man who's now in his mid-20s or late 20s to invasive squamous cancers. He was treated with radiotherapy and chemotherapy for both of these lesions. Okay, and
David, how old was he? Was he an in utero transmission, or did he acquire it as an adult from orogenital contact?
No, I think it was from childhood, because he started out pretty early. I'll get the data, how old he was on that 2002 or 2005 first exam. I think this was from infancy. Okay, unless he was precocious sexually, it was probably acquired in utero or in the birth canal. So this woman has a little bit of pleural thickening or effusion here, and these very faint lung lesions here toward the bases. She has a background of Sjogren's disease, and this is what her CT looks like, with these mostly peripheral but widespread, ill-defined, low attenuation blobs, some of them ground glassy, some of them slightly denser. And this was biopsy. The worry, of course, in somebody with Sjogren's disease and lung blobs is that it's lymphoma. But this was a polyclonal lymphoplasma cell infiltrate. And there was a mild kappa light chain predominance, but it was polyclonal. It was not monoclonal, and she did not have any cystic lesions in her lungs. So this is a lymphocyte disease of the lungs, and they're treating this as if this were, they're calling it LIP, or interstitial lung disease. People are calling it that. But, you know, the pathology was based on biopsy of this lesion down here, a needle biopsy of that. So the pathologist doesn't really know the gross distribution of these lesions. I don't think I would call this LIP. By the way, she does have one cyst. I thought she had a couple, but there's one. So it's you know, it's in the spectrum of lymphocytic infiltration of the lung. That's sometimes LIP, sometimes nodular hyperplasia, sometimes it's along bronchi, and it gets called, you know, bronchiolitis and so forth. So there's a variety of ways to get lymphocytes in your lung that goes all the way to frank lymphoma. So this was a lymphocytic, a benign proliferation in the lungs, and she's being treated with rituximab for this because she doesn't tolerate the high doses of steroids. Okay, and this reminded me of a case, and Sudhakar brought up this case again. This case I showed in 2015, a person with widespread nodular lung disease here, and it looks way fierce here on CT, just everywhere you go, nodules all over the place. And this person has a background, there's also lymphadenopathy here. You can see some subcoronal lymphadenopathy. This person's background is CVID, so it's an immune deficiency. And this tissue was biopsied, and again, this was not malignancy, it was not lymphoma. This was called focal nodular hyperplasia, lymphocytic hyperplasia. So this is another lymphocyte infiltration disease on this, in the same spectrum as the last case. So in certain situations, this could be LIP or could even be lymphoma, but this was focal nodular lymphoid hyperplasia. So 2 cases of lymphocyte proliferation in the lungs.
Yeah,
okay.
Very nice. Yep, very nice.
So
typically when they biopsy these, or at least biopsied in the past, they may have, well, they didn't have the armamentarium that they have now with respect to looking for a monoclonal population of cells by one technique or other, whether it's a PCR technique or looking for restriction by kappa or lambda light chains and so on. So it's hard to know in general what to make of these, particularly if they don't do an extensive evaluation for a low-grade lymphoma. I like to think there were patients that were diagnosed with a whole variety of lymphoid neoplasms previously in previous decades that nowadays would be diagnosed as, for example, a low-grade B-cell marginal zone lymphoma. It's a reflection of a heightened awareness, but also more things you can do to look for a monoclonal population of cells, yeah.
mhm.
Because that looks pretty florid, yeah.
And this woman's lungs cleared up dramatically with corticosteroids.
Yep, yep.
Okay, these are the cases I wanted to show.
Great, thank you. This is a patient that recently underwent lung transplantation here, bilateral. So I'll show you the progression of fibrosis over time. So this is a radiograph from 2013, and closer to the time of transplantation, she looks like that. So obviously a very extensive and progressive interstitial fibrosing lung disorder. I'll show you the CTs. The earliest one I have from 2013 that looks like this, and the close to transplantation CT that looks like this. So let me close that out and unmute those for a moment. So again, in terms of time, we have 2013 versus now. And none of us would have trouble diagnosing, of course, a progressive, extensively progressive interstitial fibrosing lung disorder. But the pattern certainly is not a UIP pattern. So this would be a non-UIP, IPF-based pattern of disease. Obviously, it's much more difficult to diagnose the pattern when it's not that severe. Back then, one might have speculated about UIP, but certainly this appearance now is, I think, really not classifiable, but it's not UIP-like. It's asymmetric. There's a lot of fibrosis internal to the lung. There's a lot of traction bronchiectasis, not just in the subpleural regions. There are foci of low attenuation, which I speculate represent areas of presumably obliterated small airways. So a really mixed pattern. So this is a patient with a very strong family history. She has both a sister and two brothers with interstitial lung fibrosis. So we don't have genetics here, but this is clearly a case of familial pulmonary fibrosis. And you can see when I asked the pathologist what the explanted lungs look like, those are some of the comments there. So no particular diagnosis other than the fibrosis, but not findings under the microscope either, typical of end-stage, very severe UIP. So certainly we've seen cases of familial pulmonary fibrosis with all kinds of patterns, not just UIP, but patterns like this that are not really classifiable. You can see I asked her whether there were any features suggestive of pleuroparenchymal fibroelastosis, and she said not. So a case of familial pulmonary fibrosis.
How old is this woman again?
This person is, at this time, 57.
Yep. Which also supports a familial fibrosis, just since she's younger than you would expect,
Yeah.
unless she had a connective tissue disease. Any history of telomeropathy, early grain in her teens or 20s,
No,
or
not
liver disease, or?
right. Not that I saw mention of in the medical record. Not that I saw, no.
So I wonder if it's familial hypersensitivity pneumonitis, given that mosaic attenuation in the base is presumed air trapping.
Yeah, that's a feature. It's not a dominant feature, but I don't know what to make of that. This has got so many patterns. It's really, I think we all agree, not really classifiable into a particular bucket with so many features. So I thought that was really quite interesting. All right. There is a patient that came into hospital with hemoptysis. He also has edema and he's got diabetes. So let me show you two radiographs. I will try to make this one like that. And let's see what I have here. This comparison on the left is from December. And when he came in with a history of hemoptysis and extremity edema, this is what he looks like on the right-hand side. And not surprisingly, the CT will look like this. So he has these consolidated opacities, very extensive, multilobar. Interestingly, there is subpleural sparing. It involves in this person more the upper lung zones than the lower lung zones, but certainly with the history of hemoptysis and this radiographic and CT appearance, this is very consistent with pulmonary hemorrhage and a hemorrhage syndrome. There was a question because then he developed signs of renal failure, whether this was lung edema, and I was quite emphatic when they asked me that this is not lung edema, and it's certainly not overhydration lung edema, but very consistent with pulmonary hemorrhage and the history of hemoptysis. So he had a renal biopsy, which actually didn't show much of a vasculitis, but he does have very high levels of the MPO antibody. So it's ANCA positive pulmonary hemorrhage syndrome. They've attributed his kidney disease to his diabetes, but I think the findings, given that ANCA positive, is very consistent with an ANCA positive vasculitis. And one entity that may do this, particularly with the MPO antibodies rather than the proteinase 3, is the entity of microscopic polyangiitis. But either way, very much a case of ANCA positive pulmonary capillaritis and pulmonary hemorrhage. And they're treating him with immunosuppressive agents for that. All right. This is curious. So I initially saw this case in the context of chest surgery, in which this particular pacemaker here, which I'll show you, was being removed. So this person has two pacemakers, and I will show you how this patient presented going back quite a ways. So you can see starting in January 2016, she had a scar from a pacemaker on the left side that was oozing, and that has been a chronic problem over years. And you can see that she has a history of pacemaker implantations going back to 1978. So this is the old one. This is the new one. You can see that over time, this continues to be a problem. That is, she's got this non-healing wound in the left chest. And this is a note, if I remember, from a plastic surgeon in the context of planning what to do about this. So they did notice, and I'll show you in a moment, that there was an incision and a protruding wire. And then finally, they took her to surgery to remove that pacemaker. So this is a pacemaker that I believe was placed intrathoracically. So people sometimes do that, particularly in the pediatric age group. And they typically place this in the chest, but extrapleurally in the chest. But I'll show you from the CT that it may initially have been extrapleural in relation to the rib cage. But if you look at this, it's really migrated in quite a distance. So it really is in the lung, effectively, I think. While some of it may be extrapleural, it certainly protrudes into the lung. So it's kind of intrathoracic. And then if you can see that up here, let me see if I can find the spot that she had this weeping wound, which was here, I believe, where you can see some inflammation, you can see some air, you can see the wire protrudes out there. And that was her focal chest wall problem that she'd been dealing with for quite a few years. But it sure looks like to me that this is seemingly really in the lung. There's airway disease associated with it, and that's where it is. So I think it's the first case of intrathoracic pacemaker that I've seen, and that was subsequently removed. Have any of you guys seen that? Here's the kind of the description of it, of an intrathoracic pacemaker.
Yeah, occasionally. A lot of them were older cases, older being just like from the remote past, not necessarily in older patients, but
yeah,
there was one that we had was, I think, an infant or something, but not, I mean, not to this degree where it's causing, that kind of finding.
What a funny place to try to put it. I mean, you'd think that they would put it in the anterior abdominal wall and just have some long lead.
Yeah,
epicardial lead.
They are placed in pediatric age groups, sometimes in the abdominal wall. But I guess someone had the idea that you can place it intrathoracically and it won't be noticeable.
So Howard, does this one have epicardial electrodes? I think it does. Anterior electrodes connected.
Let me bring up the frontal to show you that. Yep. Yeah, the old one does have exactly that. Yep, their epicardial surface. So I'm not quite sure what the indication for pacemaker placement. She may have had congenital heart block or some such as a child.
Yeah.
But do you agree it sure looks like it's breached the visceral pleura? It really is sitting in there, isn't it?
It's deep.
It's deep, isn't it? Sorry about that. Yeah, it is. There was a component of this, which I'll show you. Actually, I forgot to mention this. But there's a component of it here that really didn't come out. When I read this, I suggested that this component was calcium. And of course, I don't know what is calcified, but there's maybe some calcified tissue. So I will show you the follow-up radiograph after this was removed, and you'll see that presumably that blob of calcium, which is sitting, here's a surgical drain, which is sitting right there, remains behind, which is fine. I think it's just presumably an area of fibrotic lung or something in proximity to the pacemaker device sitting right there. Just a curiosity. But I presume this will all heal up and she won't have her chest wall problems at least, and that'll be a good thing. All right, let me show you this one. So this is a very sick patient in hospital. I'm trying to remember the clinical context. The patient, I think, was transferred here perhaps after the patient became septic and became quite ill. At this time, of course, the patient is intubated, and I will show you what the lungs look like on CT. So I'm sorry, I don't know why my Syrinx persists in doing that. So let me try and fix that. So this is, in terms of time, 1:27 and 1:31. And this is what the patient's lungs look like now. I'll make this big. So of course there's a lot of opacity in the lower lung zones, both atelectatic but consolidated lung. But as we scroll around, you'll begin to see areas of cavitation. So let me find some relatively large areas of cavitation like that. And I will find you some more like here. So this person has a necrotizing pneumonia. And here you can see other cavities forming. So this is Staph aureus, necrotizing pneumonia. But I'm showing it to you because I'll show you some Cheerios. Now, usually we associate so-called Cheerios, and I'll find a few for you, with...
Yeah, I was going to say that I saw a couple in the right upper lobe as you were scrolling down.
Yeah. So even the little guys have cavitated. So let me find you some more. Actually, let me see if I have thin cuts, which will be better to show you the little Cheerios. So I'll find those for you. And let me mag it up. And as I scroll around, you'll see Cheerios like that. And there'll be more of them. Those are some bigger ones there. Some bigger ones. But you'll start to see little small ones. So it's really interesting that even the small lesions cavitate out quite quickly with, in this case, staphylococcal pneumonia, necrotizing staphylococcal. We've all seen this kind of thing before, but maybe I haven't noticed it, but I can't remember seeing Cheerios, or maybe I'm just more aware of it now. But even the small lesions are cavitating out. Have you guys perhaps seen that?
Rarely with infectious causes. I guess that begs the question, are you sure this is all staph pneumonia? Or does she have underlying mucinous adenocarcinoma too?
Oh, I don't think so, that I know of. She doesn't have a history of...
Because even that bigger cavity there in the right upper lobe just looks like it has a weird thick wall and not a lot of surrounding inflammation. I don't know. I thought that's where you were going with this case first. That was my...
We have a mixed adenocarcinoma simulating Staph aureus. I don't think so.
Like some of them.
Pathological proof of that.
Or both. Yeah.
But she had blood cultures positive for, let me see here, for that. Oh, I don't know if the diagnosis of influenza is right, because I don't see parenchymal findings suggestive of viral pneumonia. But a blood culture did grow methicillin sensitive FSA. So if ever I find out that I'm wrong, I'll show it to you and I'll apologize. But I thought they were great Cheerios, and I just assumed it was all the same thing.
Yeah, no, and it may be. It's just, doesn't it make you a little nervous? Just because even as you said, it's like we don't usually see these with run-of-the-mill pneumonia.
I think she's got two things simultaneously, huh? Wow.
Oh, I don't know. I mean,
yeah, probably not. But
I don't like to invoke that, but you never,
yeah,
you never know.
Point taken. You never know. We've shown weird things, of course.
Which also, gets to the point of doing follow-up radiography just to make sure pneumonias go away, especially in older patients.
Yeah. You can see this person is 61.
And you said she had underlying, did you say diabetes?
That was the...
that was the previous.
Yeah. All right. I think I have shown you my 4 for this week. So unless anyone has any...
let me double back on a couple of these.
All right. Sure.
Since we've got a couple more minutes.
Oh, yeah.
So while you were showing that case, Howard, I was able to pull up the case that I had from memory. And as you can see by my numbering, this was very early on after we started anonymizing cases. But this was a 22-year-old, and my notes said that this was placed as an infant, and they placed it inside the chest. And you'll see here that it's similar to where yours was. It looks like it indents the pleural surface here. It's certainly not in the fissure like yours was.
Not as, but
yeah. But yeah, so this was the case I was thinking of, and yeah, so it was placed during infancy. But I think that's the only one I had in my teaching file. So, but that was placed a long time ago.
Right.
But very similar, and to David's point too, that they're epicardial pacer leads like this.
Yeah.
So.
And it's interesting they chose the same locations, kind of basal, lateral of chest.
Yeah.
So Travis, was there fat next to that, lateral to that thing between the device and rib?
No, I think this is actually lung right here.
It's hard to tell with all.
There's so much streak, but that looks like lung. It just looks like it has a different. It just looks like it's a little more. Oh yeah, it's clearly lung parenchyma there.
So it's in lung again then.
Shouldn't.
Well, it's right. It's in, there's some little fissure, or I don't know if it, as the patient developed it, the lungs
Goes
kind of
around.
grew around this.
Because
Yeah.
they describe them as being implanted extra plurally, not
Yeah.
yeah.
Yeah, because you almost wonder, in this area of lung right here is hyperinflated relative to the rest of the lung. It looks like it's coming from the basal left lower lobe, and maybe it just kind of grew around this thing.
Yeah, in some fashion. And it's just
Yeah. Huh.
thing.
Howard, I'm glad you asked about the removal of this drill bit, because not only was I able to look at the note, I actually went back and found these fluoroscopic images.
Oh,
So this is their bronch. Just wait, yeah, because this is a pretty cool video that I just found. So it's a micro snare.
Okay.
And I will I'll play it, and you can see. Hopefully, it shows up pretty reasonably smooth.
Yeah.
So they're putting the snare around the neck of this thing, and they're just going to start to pull it back. Oh, that's the first video. So they've snared it. Here's the second video, and they've already started to pull it back into the trachea. Yep, and then the third video, they just pull it all the way out, as you'll see here. If it actually runs.
Okay, so they've got the scope in there, and they've got that device inside it.
Yep, and there it goes. So they did it under fluoroscopic guidance and just pulled it out.
Very nice, very skillful.
So yeah, that's kind of fun. I'll show this one. I don't know if how much of this you guys are doing. We don't see that this often here. We don't do this. One of our interventionalists does this. But this is a lady who's had prior adenocarcinomas resected. You can see a staple line there. And she had this new nodule here that was biopsied, or not new, but it was growing. Biopsied as another adenocarcinoma. And you can see probably one in her left lower lobe as well. So rather than resecting more lung, she underwent a microwave ablation with interventional. And I have several follow-ups that just show you. So this is the original follow-up. Kind of cool how it, there's this large area. Well, let me see if I can actually unsync these. Yeah, so the nodule, and then they just obviously ablate a large field around that. But this is kind of what it looks like originally. So presumably this is a lot of hemorrhage and just necrotic lung from the actual thermal ablation. And then they subsequently, I'll just show you the evolution of this. Do you guys see this that often? The
not too
microwave ablation?
But we do some. We do some, a few.
Yeah. It's kind of interesting. A bronchogram going right through this thing, and then it just starts to excavate.
Yeah.
And now this study here, it's reduced in size, and this was all just fluid attenuation. It was between 20, close to fluid in some areas, and it had just totally filled in with fluid. And then they did a repeat PET, I think, just because, I don't know, this got done somewhere else, this follow-up study, and they weren't sure about this, but the size is unchanged, and there was really no metabolic activity in that thing. So just kind of showing the evolution of these. I don't know, because they were wondering if there could be any sort of recurrence, but it just looked like it continued to get smaller, and there wasn't really substantial metabolic activity in this thing, maybe just a tiny rim medially. But we don't really have that much experience with those, but to me this looks, from what I've read and what I've seen in the past, it looks pretty good.
Yeah.
For what
So
these things
you think that'll
do.
shrink down ultimately and just leave a little scar behind?
Yeah, I would think. I mean, a lot of this was fluid attenuation, so I guess if there's just a hole that's filling in there, or if it will all just eventually scar down. We're just going to continue to watch it, though.
Yeah, once in a while. I'm not sure if it's done that much anymore because we have PET, but they used to ask us to do so-called dynamic densitometry. In other words, you just give contrast medium and you scan at one level over a period of time to look for any residual enhancement in the ablated lesion to try and infer the presence of an incomplete ablation, perhaps.
Okay.
With contrast.
And you can kind of see
with contrast.
It's like 15, 16 Hounsfield units.
Yeah, who knows how much it'll scar down. Maybe a little,
Yeah.
a lot, maybe not so much if it just organizes up.
Yeah. I don't know. But I thought those other, like this study in particular, this PET was just a pretty cool look.
Yeah.
That one air bronchogram and this big just void right here.
Right. Can you see, is that a linear track from the actual device going through it, seemingly? Maybe.
Oh, I just thought that was an airway. This thing right here.
Yeah, very linear. I wonder what if that is an actual track.
There's a looks like a pulmonary artery branch that's right next to that.
Oh,
I was just assuming that was an artery, and this is unfortunately from the PET. But here, this is a diagnostic CT.
Oh no.
Yeah, I think that's just an airway.
Oh yeah. Okay.
Yeah, you can even
Okay.
You can see it branching distally
now
there.
I see it contains.
Yeah, so it kind of I guess the airway was able to maintain its architecture and structure in this thing.
Yep, sure.
Yeah.
So what does the device that they feed out there look like? Is it a very thin little catheter that can go up way peripherally, or is it a big honking thing?
It's a big thing with little like tines, multiple tines, I think.
And they do it percutaneously.
Oh, really?
It's not an endobronchial thing.
Okay.
Yeah. And it's similar to what you do with microwave ablation, I believe, for bones, what some of the MSK and interventional folks will do. I'll try and find a picture of one. And then just really quick,
cooking the tissue. It's like a microwave oven, then you're just heating.
It's thermal ablation, yeah. And I'll just show this one really quick because this was more my reaction to this was excitement, but then it turned out it wasn't really, it turned out it was intentional and not unintentional. But this is just portable. Patient then undergoes median sternotomy. I think they underwent emergent coronary artery bypass grafting. But of course, that's not the important thing, and nor is that. But this guy right here, and of course, you can see there's a little floppy J-tip on the end, and it's confined to the aorta. So I got very excited thinking that this was a retained femoral access guide wire, which it was. It just turned out that this was intentionally left behind, that they had it in anticipation that they might have to place a femoral intra-aortic balloon pump. But it's been a while since I've seen a retained guide wire. I think it may just be maybe a testament to my clinical colleagues here, and that they are very vigilant. But yeah, David, you remember some of the ones I showed from previous hospitals that I've worked at. So
yeah, some wires that got away.
Some wandering wires. Yeah, but this is a nice one, just just to show your residents too, just to make sure they're attuned to it. But yeah, this was intentional. So.
Very good.
All right, Howard, that's enough for me here.
All right, everyone, that was great. Thanks for showing. Same time next week.
Yeah, I think Jeff will be back next week. Hopefully, we'll see some others too. So take care.